Welcome to the Forum, live streamed worldwide from the Leadership Studio at the Harvard T.H. Chan School of Public Health. I'm Dean Michelle Williams. The Forum is a collaboration between the Harvard Chan School and independent news media. Each program features a panel of experts addressing some of today's most pressing public health issues. The Forum is one way the school advances the frontiers of public health and makes scientific insights accessible to policymakers and the public. I hope you find this program engaging and informative. Thank you for joining us.
Hi everyone and welcome. My name is David Freeman. I'm the editorial director of NBC News MACH, that's M-A-C-H. I'm also the moderator for today's panel discussion, which is entitled Stroke, Successes and Setbacks with a Notorious Silent Killer. Stroke prevention, treatment, and recovery in the U.S. is really a remarkable success story with many lives saved over the past few decades. But recently there's been a worrisome new trend of people having strokes at earlier ages, and progress against stroke has stalled in some parts of the country. What's driving these trends and what innovations and technologies might help curb them? To help answer these questions, we have our esteemed panel here today with us, starting from my right, Janet Wright, who is Executive Director of the Million Hearts effort at the CDC and Centers for Medicare and Medicaid Services, Umberto Kempia, cardiologist and vascular medicine specialist at Brigham and Women's Hospital, Gökhan Hodomishligil, who is chair of the Department of Genetics and Complex Diseases at the Harvard Chan School. And also joining us remotely is Walter Koroshetz, who is director of the National Institute of Neurological Disorders and Stroke. This event is being presented jointly with NBC News Digital. It's also part of the Dr. Lawrence H. and Roberta Cohn Forums, and I'm pleased to have the Cohn family today. We're streaming live on the websites of the Forum and NBC News MACH. We're also streaming live on Facebook and YouTube. The program will include a brief Q&A at the end, and you can email questions to theforum@hsph.harvard.edu. You can also participate in a live chat that's happening on the Forum site right now. Excuse me. So to set the stage, let's take a look at a video from NBC Nightly News about younger people having strokes.
We're back with a new warning about the alarming rise in strokes for a surprising age group. At a time when strokes are declining in older Americans, they're also skyrocketing for younger adults. NBC's Erica Hill has more on the risk factors you may not have heard about until now.
Always active, Chelsea Colangelo thought she was healthy until she collapsed at age 28 with a stroke.
It's scary because you can't move and you can't speak.
This is Colangelo just a few weeks after.
No bathroom cleaners.
Trying to read a children's book. She had to relearn how to communicate, walk, and dress.
While left side, it's numb, pain.
Strokes aren't often associated with people in their 20s or even their 40s, yet those numbers are on the rise. A new study by researchers at the University of Southern California found over 10 years there's been a 44% increase in strokes for 25 to 44-year-olds, while strokes for those over 65 decreased. The big question, why is this happening? Among the risk factors, according to scientists, sports injuries, hormonal changes from birth control, undiagnosed heart defects, and an increase in diabetes and obesity. While the vast majority of strokes every year, 90%, affect those over 50, experts say the symptoms of a stroke may be less recognized by younger people. A sudden loss of control in your nervous system, symptoms that spell fast, facial drooping, arm weakness, and speech difficulty, all signs it's time to call 911. Now, more than a year after her stroke, Chelsea has made remarkable progress. While she may never know what caused it, she hopes it will serve as a wake-up call for others. Erica Hill, NBC News, New York.
Also, we saw some of the risk factors there, but this is your field. So what's going on here with this increased incidence of stroke in these young people?
Yes, why is this thief, this villain, this stroke sneaking back in, and why is it getting to our younger age group? studies that came out in around the same time as the one that was featured in that clip showed that death rates from stroke have stalled across the country. You all know we've been seeing this beautiful decline in both heart disease and stroke deaths for 50 years, dramatic decline. And that has begun to flatten or plateau, and in some places go up. And in fact, if you look at a map of the United States, one of the things that's most striking is that stroke is no longer just a stroke belt issue anymore. We are seeing this stalling of stroke death rates from Maine to California in states where you would be shocked. We also looked at hospitalizations for stroke and saw this rise in hospitalizations in the 35 to 54-year-olds, actually 18 to 54-year-olds. More of that age group being hospitalized, and when we took a closer look at those folks, many of them had stroke risk factors, the classic stroke risk factors, even though they were 18 to 54 years old. One of the metrics from one of those studies looked at those that had 3 to 5 risk factors, so really a lot of risk for stroke, and it was it had doubled in a 10-year period in that age group. So I don't think it's a mystery why we're seeing these. Decades of obesity, physical inactivity, and diabetes, those 3 interwoven factors, are eventually now having an impact on event rates.
Just quick, you mentioned the stroke belt. There's things happening outside the stroke belt. Tell people about the stroke belt, where that is.
Yes, the stroke belt is typically known as the southeast part of the United States. It's where I grew up. Very high density of strokes and heart attacks for many years now.
Okay. Umberto, you treat patients, so you're a clinician, so what are you seeing in your office?
Yeah, it's very important to highlight the fact that there has been a group of younger people that have suffered from stroke from causes that are sort of not under our control, such as having a defect in the heart or having some clotting abnormalities. Those are not the ones that we see more often. The ones that we see more often are the younger patients that have lost their control of activity, so they're very sedentary. They have increased their weight. They have engaged in very unhealthy lifestyle, particularly with regards to eating habits, increased calorie amount, increased sodium intake, and decrease in their activities. This leads to the onset of what we call the metabolic syndrome, which is a state in which the body is in an abnormal environment with regards to inflammation. Also, there is an abnormal lipid environment. The cholesterol is not particularly high, however, the good cholesterol is low. The bad cholesterol is relatively increased, but this combination is particularly dangerous. This causes damage to the vessels, and in association with the high blood pressure, this leads to the early onset of atherosclerosis. So we are seeing more and more of these patients, and unfortunately the understanding of the risk associated with the early onset of these risk factors is really not widespread. And many times I see patients that come to me young, obese, hypertensive, who are not given the appropriate advice about exercise, who are not on blood pressure medications, and who are not on appropriate treatment for their obesity.
So Walter, the National Institute of Neurological Disorders and Stroke, of course, is responsible for a lot of research on stroke. So what do you see as the areas that we should be focusing on in light of these kind of worrisome new trend?
On stroke goes back many, many decades, and I think the answer is actually staring us in the face, and that is that the major driver of stroke is hypertension. The second most important driver is hypertension, and the third most driver is hypertension. And we think that 30% of the people in the United States have hypertension, and only half of those have their blood pressure controlled. So in our sense, from looking at the data, the challenge to the U.S. is putting into practice what we already know, and that is people need to know their blood pressure, and they need to get their blood pressure under control. The controversial area is how low we should drive the blood pressure. Unfortunately, all the data that we have so far shows the lower the blood pressure, the lower the risk of stroke. We don't know where the bottom is right now, but we do know that lowering blood pressure will decrease your risk of stroke, and that is, basically so the evidence is so clear that we really need to act on that in this country.
So the 120/80 target doesn't really hold anymore for people who are trying to control their blood pressure who are at risk for stroke?
Well, that I think is the area that we don't really know how low we should be going. We recently funded a study at NIH called the SPRINT study, which was aggressive blood pressure lowering and below the 120, and the study had to be stopped prematurely. The mortality rates were so much lower in the lower blood pressure group, and that. The only caveat there being that those patients were people who had risk factors, kidney disease, heart disease. So in that high-risk group, you should go even lower than what was previously the 140/80 regimen. What we don't know is how that applies yet to the general population who does not have those risk factors.
Right. Okay, thank you. Gökhan, you researched basic biology of stroke. So looking at what happens inside the body to put people at risk for metabolic disorders. Tell us more about what you're learning in your research.
Yeah, thank you, David. I think I'll start by saying that I'm not really an expert on stroke, but more study the processes that establish the risk factor for stroke and vascular disease, both in the periphery and in the brain. And so I guess one of the main things I would mention is that there is a tremendous similarity between how the body fails either during aging or obesity, and the brain fails using very, very similar mechanisms. And I want to put things in perspective. I mean, although, for example, when you have diabetes, this risk for stroke increases by 2 to 4-fold. So on the surface, it may appear as a low number, but the magnitude of this is tremendous. The reason for that is in the US, for example, 1 out of every 10 individuals has diagnosed diabetes. 1 out of every 3 individuals is estimated, and this is a really alarming number, to have prediabetes. So they are destined to develop diabetes, or they have signs of diabetes, but they're not yet aware of it, or it's not diagnosed. And of course, again, depending on the numbers, 1 out of 3 or 1 out of 4 has obesity. So such a large section of the population is influenced by these risk factors that it really contributes a tremendous amount of burden on the health system and the welfare of people and quality of life. And so I think the reason that we study why, for example, similar things happen, and could these be exploited for treatment of stroke, but perhaps together with the treatment of diabetes, insulin resistance, hypertension, obesity, and other metabolic abnormalities and inflammatory problems, which are very closely interwoven to address the problems of people suffering from stroke or the risk for stroke. And so there are, I mean, many things. Actually, in this school, we have a whole department devoted to study these risk factors. And so they include, for example, inflammation, both in the peripheral body with these risk factors and in the brain. There is chronic inflammation. So this is different inflammation than what happens, for example, when you sprain your ankle. It is a low-grade inflammation that is not resolved. There are abnormalities in lipid composition, but not limited to lipids. Many other metabolic abnormalities at the neuronal level in the brain, but also in the peripheral tissues. And lastly, perhaps the defense system. So our bodies are equipped with defense systems to deal with stresses, damage, insults, noxious events. But these management systems also fail in the course of these metabolic abnormalities or obesity, for example. Therefore, not only you increase your risk, but you also reduce your ability to deal and recover with the insult. So at many layers, these problems contribute to the problem, both emergence and the prognosis at the same time.
Okay, so we've talked a bit about some of the drivers of stroke, but let's talk about innovations now. Here's another clip from NBC News that describes a procedure that saves lives by removing blood clots, but another part of the story is the importance of new guidelines about when doctors should use it.
A simple walk with her dog is a miracle for Cynthia Dodd. Less than a year ago, the 46-year-old suffered a massive stroke in her sleep.
I would have died, and if I did live, I would be complete vegetable.
By the time she was found in the morning, it had been more than 6 hours, which had been considered too late to remove the brain clot and save the patient. But now, new guidelines from the American Stroke and Heart Associations say doctors have up to 24 hours to use clot-busting devices like this thin wire.
It's a massive game changer. We've had these devices now for a period of time, but now we've expanded the window that we can intervene and act on patients.
And that's the life-saving part.
Life-saving and improving their recoveries.
One study found that expanding the window of time to even 16 hours cut in half the number of deaths and severe disability.
With these treatments, you more than double the chances of someone being independent in the time after their stroke rather than being severely disabled.
It's still crucial to get to the ER right away. Luckily, Cynthia Dodd was sent to Stanford Hospital, already testing this approach.
I knew that I was lucky to be alive, but when you see your brain up on that computer and you're like, that was me? Like, how am I even sitting here?
Now this mother appreciates even the simplest moments, thanks to a radical change giving doctors more time to treat. Dr. John Torres, NBC News, New York.
So, Walter, what are some of the advances in stroke treatment that the Institute is particularly interested in?
Well, I want to just emphasize the message that you just heard, which I had the opportunity of being in the development of these technologies years ago before I came to NIH when I ran the stroke program at Mass General. And it's nothing but a miracle to see someone come in with is clearly going to be a fatal or completely disabling stroke. But then when you remove the clot and the blood flow goes back to the brain, the patient walks out of the hospital seemingly the way they were before they had the stroke. So it is an incredible miracle. Now, the one piece that I don't want people to misinterpret is the business of the timing. Let me be clear. When the blood flow to the brain is cut off, the brain cells start dying within minutes. What we've learned is through using advanced imaging technologies that we can look into the brain and see how much has been damaged and how much is still ready to be salvaged. And that sets the decision making to intervene. But from what I've said, it's pretty clear the sooner you intervene, the less damage is going to be. What we did find out is that there are some people out to 16 hours, say, who still have brain tissue that can be salvaged. But they are the vast minority. They are exceptions. So it is critically important that this time window expansion, it's a very small group that actually benefits from that time window expansion. People really have to get into the hospitals very quickly for this technology to help them, or else they'll be excluded because they get the brain scan and there's nothing left to save anymore. The other thing to add is that what's happened since the NIH study of thrombolytic therapy for stroke in the mid-90s, the way stroke is practiced has changed dramatically across the U.S. Because now the challenge is to provide these therapies to people incredibly rapidly. And before 1990s, that was not the case, and people would languish because there was very little one could do for them. But the strain on the hospital systems to change how they treat stroke, to communicate with the ambulance drivers so that not a second is lost, is what has really changed how stroke is cared for in the U.S. But it is something that's been tough to do because of the financial strains of many of the hospitals. So we face a broad inequity in the United States in terms of people's access to these therapies that the hospital systems are still now trying to equalize.
Well, we'll talk about disparities again in a bit, but I want to go to Gokhan about your perspective, more about, I guess, drug focus rather than interventions for surgical interventions.
Yeah, I think on the drug end, there are many extremely promising technologies developing, and that maybe they could be categorized, and we can come back to this. But of course, one thing I want to mention is stroke. Like many other diseases that we do, we use a very broad term actually to cover many different types of diseases. So stroke is not a single disease. And I mean, there are broad categories for example, hemorrhagic versus ischemic, meaning due to bleeding versus due to cutting off the blood supply to the brain. Both can cause. Obviously, these will have different types of approaches to deal with. And then under each, of course, there are many different categories. And so of course, the best solution would be not to really see patients having stroke. So that means developing a panel of markers that could be predetermined, and depending on the risk profile, people can actually be put on preventive measures, whether they're primary or secondary preventive measures, so that they really do not have to face the burden of the disease and the potential consequences. So there, I think the key is really dealing with the risk factors. And I mean, we heard some of those, dealing with hypertension, dealing with metabolic disease through both lifestyle changes, dietary changes, but also I think more and more now it's becoming quite likely that these will be intervened by very simple and low-risk medications. And the second area of drug development, of course, is to increase the possibility of recovery. So some people eventually will suffer from stroke. And how can we help? In addition to removing the blockade or stopping the bleeding, how can we help brain to recover? So there, I think also, I mean, tremendous progress, both in medications, which will prolong the time. So they could be even administered at the time of diagnosis until the time that intervention could be made. That will increase the chance of survival for brain cells. And so even when you open, let's say, a blockade in a vessel that is feeding the brain, that itself can actually create problems. So this is called ischemia reperfusion injury. So, and this is, of course, also a time-dependent event and also dependent on the magnitude of the blockade. But there are interventions now that could be employed which will reduce the chances of this injury so that when the blood flow is restored, nutrient flow, oxygen flow to the brain is restored, the cells have the maximum capacity to recover. And lastly, I would say, although this has not yet broadly entered clinical practice, I think perhaps the last avenue would be to replace or repair the damage. And so some, for example, neurons will die, and of course it is not possible to revive the dead neurons, so they need to be replaced or re-derived from their neighboring cells or cells that have the ability to give rise and replenish these populations. And for those that are not quite dead but severely dysfunctional, there will be interventions to actually recover them close to their normal functions. So these will be the general areas. But I think I'm really most interested in areas that we can develop better diagnostic tools, better biomarkers, and better preventive interventions than what we have at the moment.
Well, thank you. Well, Walter's mentioned some of these disparities, and of course you alluded to disparities as well. So, Janet, tell us what's going on with these disparities. What are the disparities and why do they exist?
Yes, they're, in addition to the age one that we talked about, we know for years now that African Americans and blacks suffer a higher rate of stroke, and it relates back to the higher rate of lack of control of blood pressure. We've seen great advances in African American and black populations who are now very much aware of hypertension. We've seen increases in treatment, but the control rates are still flagging far behind. And as Walter's pointed out, African Americans with hypertension have a much higher risk of stroke than a white person who might have that same blood pressure, almost 3 times the risk of stroke. So there's something going on there that's intrinsic to that subset of the population. We've also seen increases in stroke death among Hispanics at a 6% rise per year over a couple of years, 2012, I believe, and 2013. So these are very frightening changes. What we are coming to understand, and this sort of gets back to Gokhan's wonderful point, is the best stroke is the stroke that got prevented, the stroke that never happened, is that the things that work, we know what works. We know what works to prevent stroke. We know what works to prevent heart attack. And it's not, those things are not getting implemented everywhere for everyone. Those things that need to be working in the community where people live and work, and those things that have to happen in healthcare.
Well, it's interesting. So Umberto, with your patients, you're seeing patients all the time who have issues. So what's your perspective on people who are struggling with some of these risk factors?
So this is really at the focus of our intervention. First of all, we should be informing our patients. Many times patients come to us and they come just for referral for some issues, and then we discover that they have a lot more going on, and the information is the first element of our treatment. The other component is education. So many times patients who are busy with work, who are struggling many times with a social environment that is very challenging. Patients have to work sometimes 2-3 jobs to make ends meet. They live in an environment where there is a food desert. There are no Whole Foods, there are no major venues for healthy food purchase. And when they are there, they may not be able to afford it. It's incredible to see how expensive it can be to have a healthy lifestyle. And many people don't have the place, don't have the means to afford that. Then the other component is education with regards to the importance of other healthy lifestyle choices, particularly activity. Weight loss is the most effective way to reduce high blood pressure without pharmacologic intervention, to reduce the risk of diabetes. Trials that have looked at activity as an intervention to reduce the risk of diabetes have shown that it is twice as effective as the best drug that we have to reduce the risk of diabetes in patients who are at risk for diabetes. So counseling on this type of intervention, but also providing logistical supports to allow them to exercise, to have the time to exercise, to get the appropriate food on the table rather than just having to go to the frozen section of their local supermarket to get some vegetables. Those are some of the aspects that we as physicians should be focusing on. The other aspects that we can use are smoking cessation. Smoking cessation is one of the most challenging aspects of my practice. Many times, and just I was in clinic this morning, I have a patient who had he had a heart attack, but he's obviously at risk for stroke, and he's taking his medication. His cholesterol went down to 52 of LDL, which is an excellent result. It was easy for him to take this pill, but he's still smoking. And I've tried with smoking cessation counseling, then I've tried with pharmacologic intervention, with nicotine lozenges, and now I have just one bullet left, which is this other drug, varenicline, that can help him. But it's been 6 months and still I have not been able to successfully have him quit smoking. So the importance of addressing this issue is always to remember, but also we should be able to give logistical support to our patients to make sure that they have the means to obtain good food and to exercise many times. Now, the last but not least important aspect of education is the awareness of what the symptoms of a stroke may be. Many times patients are aware of having limb weakness or having speech impairment. At the same time, they may not be aware that a transient change in their vision, blurriness in their vision, sometimes transient loss that lasts a few minutes, and they say, oh, okay, I had, some black view on my right eye. That's nothing to be worried about. And instead, if they had recognized that early sign of ischemia, that could have led to a more timely intervention and prevented maybe a disabling stroke. And that's why the campaigns that the American Heart Association has been implementing are of fundamental importance and are one of the most useful tools that I can think of to educate the public.
Oh, thank you. So, Walter, did you want to say anything about that? I do want to move ahead with one other question. We'll give you a chance but to give you a chance to weigh in about that, about what can be done to, reduce some of these risk factors in patients.
Well, I think the lesson that we've learned, to identify what the disparity is.
Whoops.
All agree make a difference, you can make a difference. So the best example is in looking at hypertension control in African Americans, which, as Janet mentioned, is way below what it is for Caucasians. And that was true across the country until many of the healthcare systems in Northern California decided that they were going to take it on, and they completely obliterated the disparities. So I think the message is some problems, we don't know the answers and we can't fix them right now, but this is not one of those problems. We know how to fix this, we just need the force and the energy to do it.
Oh, go ahead.
If I could just play on that. Thank you, Walter, for that tee up. I just want to share one example of an innovative approach that, if scaled and spread, could really help us with blood pressure control. The late Ron Victor at Cedars-Sinai has been working in barbershops across the country for years. You all know about this. But the last study that was published in the New England Journal showed a dramatic drop in blood pressure using a model that was randomized at the barbershop level. For those of you who, I see a lot of heads nodding in the room, but those of you online who may not know about this, they used a model where the patrons of the barbershop were cared for by a pharmacist who was in the shop, and patrons were referred to that pharmacist by the barber. And in that model, the pharmacist was working with a clinician who was not in that office, but pharmacist working off a protocol, frequent visits, engagement and in education along with that, and they showed a dramatic drop in blood pressure, much more so, 3 times more than most of the studies show. So our model for blood pressure can use some innovating, being based in the community, using a broad team, and then driving towards that result using a protocol that, again, could be administered by a team and supervised by a clinician.
Interesting.
Yeah.
Very interesting. So I wonder if we could shift gears, though, for a minute and talk about recovery. And Walter, I want to go back to you about this, about what are some of the advances in stroke recovery that you think are worth discussing? Oops. We're having sound problems, so maybe we'll come back to you later. I don't know if can you hear me? We'll come back. Gokhan, what about drugs? Walter, I guess, was going to talk about some surgical interventional stuff. What about possibility of new drugs for stroke recovery?
Yeah, so when an injury happens anywhere in the body, including the brain, there is a series of events. So they're intended to repair. For example, inflammation itself is a very necessary response for an injured organ or tissue. But these actually are compromised either by the risk factors that cause a stroke, or after a prolonged duration, they themselves become damaging. So there are now, for example, immune cells will come to the environment to clean up the debris or start the healing process. But if you are suffering from predisposing factors, the brain could be populated predominantly by the damaging types of immune cells. For example, kind of macrophages, the presence of which would not be very helpful. And there are now interventions, for example, to change the direction of these macrophages or immune cells more towards a repair behavior. So this and other ways that would facilitate, for example, resolution of the injury response or strengthening the neuronal survival despite the insult are very promising drug development avenues. But maybe I want to mention again two things. Maybe speaking of disparities, there are even, more basic disparities that we haven't really had a chance to talk about. For example, difference between males and females, and this obviously will play into both management or risk factors, testing of drugs. For example, still many clinical trials are biased between males and females. And also selecting the appropriate intervention. Again, young and old, for example, very different set of risk factors and responses. And lastly, I think we have now great tools to really do things with higher precision. And many of I completely agree with what Umberto says. So there are lots of things that can be done and should be done more effectively with lifestyle, changes in habits, dietary routines and so on. But our success rate is not great in implementing this. So of course there are many reasons, part of which is we're not able to implement these effectively and broadly around the world. The second, perhaps, possibility to consider is that people need help. If we can reduce the threshold by which people will benefit from their changes in lifestyle. For example, Umberto was referring maybe a little chemical needs for someone who's trying to quit, or a little medicinal help for someone who's trying to lose weight. These will be very important. There will never be a magic drug that you will take and it will prevent all the risk factors. So I think if people are waiting for this, it is not going to happen for several centuries. So you really have to, even if there are wonderful medications, you'll still have to work and change your lifestyle to benefit from these.
But you said there's not going to be a magic bullet or pill for preventing stroke, but also seems one of the issues is that there's a lot of, seems to be some confusion or a lack of consensus about stroke guidelines. Mm-hmm. Can you talk a bit about that, about this kind of confusion that exists within the medical community?
Well, I think that, I have colleagues here who are much more knowledgeable on that topic. I'll leave commenting on that, but I think part of that really deals with maybe gaps in our understanding of the mechanism. So if we can't understand the mechanism giving rise to a disease, it is very difficult to make the most effective recommendations, whether they are preventive, lifestyle changes, or medications. And with the same token, if we look at the medications available to us right now, for example, things to treat diabetes, things to treat dyslipidemias, high cholesterol, many of these are not really targeting the mechanism that gave rise to that problem in the first place. They're just dealing with the problems. Most diabetes drugs reduce blood glucose. Most dyslipidemia drugs reduce lipids. But they don't really target the original mechanism which gave rise to that abnormality in the first place. Mm-hmm. So I think we do have the tools now, so we don't have to limit ourselves with the traditional measures or things that are available as the low-hanging fruits anymore. So we can develop much better biomarkers. There are biomarkers right now, the combination of which, for example, can determine risk for diabetes with great accuracy. In type 1 diabetes, this could be up to 99.9%. So everyone who is going to develop type 1 diabetes could actually be predetermined. And similar approaches are now with the advances in proteomics and metabolomics, so the ability to look into all things in blood to determine risk factors for obesity, other complicating factors, and stroke. So this might be one area which will increase the efficacy and maybe reduce the debate on what to do.
Well, let me ask each of you also. So, Umberto, what's your perspective on this about how doctors should be advising their patients?
I think that the way that we should approach would be first to establish a trustful relationship. You need to have a patient that trusts you so that you can build a relationship that goes beyond the simple prescription of a medication or an exercise program. Once you establish that trust and that relationship, then I think it's a work that has to be done together. You have to assess what really is the patient's ability to follow your prescription, the ability to achieve the goals that you want them to achieve. And this is not a one-time stop. We need to work with the patient and see them frequently.
5, 6, 7, 8, 9, 10.
Blast off.
And one of the aspects actually that is highlighted in the most recent hypertension guidelines is a home monitoring system. So one of the things that I always try to do with my patients is to educate them to use their blood pressure machines at home. If they don't have one, I try to get them one if they cannot afford them, and teach them the appropriate way so that they can measure their blood pressure. Many times that empowers them and they can see how effective taking their medication is on keeping their blood pressure under control. Also, it can help to see if the patient has developed side effects, if they're developing low blood pressure. So it is a mutual work that in time can achieve important goals. The same is for lipids, particularly with statins. Many times there is a lot of disinformation about statins, and patients may be afraid of taking a statin. In most cases, patients can tolerate statins. If not, we have alternative treatments that can be as effective as statins now, that can achieve the targets and reduce the risk to where we want it to be.
What about your perspective? And also, where can people go, the public go, to get more information about this?
Yes,
this
I'm
is for
so
you,
glad
yes.
Umberto brought up home monitoring of blood pressure. I think the way you asked the question was, what can the clinician do, what can the doctor do? And I think it is, one of the things is to practice in teams and to make sure that that individual, that patient is sort of the head of the team, but working with pharmacists, working with health coaches, we've done a project with community health centers across the country where they're helping individuals who have high blood pressure use home monitoring. There's a wonderful video available on our website, and I think also at nachc.org. But it tells the stories of people who are able to monitor, and they're gaining control of their own blood pressure. The great thing from a clinical standpoint is it keeps you from over-treating someone or under-treating someone. So it is the best way to help achieve safe and maintain safe levels of blood pressure control.
Okay, thank you. Well, we've got a few minutes before we take some questions. I want to talk briefly about stroke and dementia. And Walter, I think your sound is back on, so I wonder if you would talk with us about the connection between stroke and dementia.
So I guess we're good, huh?
Okay.
Can you hear me all right?
Yes.
Okay, great. Yeah, so as people probably know, I've heard that one of the great medical crises that's facing our country is the increase of dementia, which occurs as our population ages. And so NIH and many people and institutions across the country are trying hard to kind of get ready for that and try to make a dent in that epidemic of dementia. What we know, however, is that one thing that does seem to put you at very high risk of dementia is having a stroke. And also the vascular risk factors we talked about also contribute to your risk of developing cognitive impairment and dementia after stroke. Some of this we can actually see on MRI scans in the deep white matter parts of the brain, where 80% of people who are 80 years old have developed abnormalities in this wiring of the brain, which we think is also related to this problem of cognitive impairment. And so we feel that the data is such that one other reason to control your vascular risk factors is to decrease your risk of dementia, along with decreasing your risk of heart attack and stroke. And so that's something we can put into play right away. There is, however, a great deal more to be learned about the individual person and what their individual risk factors are that contributed to their diagnosis of Alzheimer's disease, which turns out to be in our country not just Alzheimer's disease, but most of the people, especially the elderly who are diagnosed with Alzheimer's disease, have a combination of vascular disease and Alzheimer type biology. So this vascular component we've been talking about in relation to stroke is probably equally as important in your risk of developing dementia. And again, we think it's something that's modifiable for the reasons that people talked about today, whereas we don't yet have modifiers of the Alzheimer side of the equation.
Okay, thank you. Janet, did you want to talk about the link between dementia and stroke?
No, Walter has covered it beautifully.
One thing, Gokhan, you...
He's tired of hearing me say this over and over
Okay. Well, why don't we move on to Q&A, because we want to end up with a kind of a prediction from everybody, but let's go briefly to Q&A if I can get the iPad up again. Whoops. Oh, well. All right, I think I have a paper version here. So this has come in over the internet. We'll come to the audience also, but I have a couple of questions here. Considering the numerous negative side effects, why is warfarin still being prescribed as treatment for recurrence of stroke as opposed to aspirin? It is cited that they were about equally effective. I think it's a citation of a 2001 New England Journal study. Who wants to take that one?
Well, I would say it depends on the cause of the stroke. So if we consider the main causes of stroke, we can divide two, and we are talking about ischemic stroke. So a decreased blood flow to an area of the brain that causes a permanent damage. So if we consider the causes of the stroke, we can have either the disease of the vessels that bring the blood to the brain, the carotids. And in that case, what happens is that the plaque, where the cholesterol plaque is, has a sort of rough surface that causes the formation of clots, platelet clots, that eventually detach from that surface and travel towards the brain, where can they block the blood flow. In that case, the treatment is with aspirin or other agents that affect the sticking of the platelets. So we call it antiplatelets. We also have other agents that can be used, but aspirin is the most common. Now, the other large contributor to stroke is the presence of clots that may form somewhere else in the circulation and then can travel to the brain. And the most common area where the clot forms is in the heart. And this type of clots is not affected by platelet to a significant extent. It's mostly the clotting factors in the blood that sort of form this plug. In that case, warfarin is the treatment, or now we also have newer anticoagulants that have overcome some of the limitations of warfarin. Now, in some patients, warfarin, despite the fact that it requires monitoring, despite the fact that it has interaction with other drugs, with food, is the only option. If a patient has a mechanical valve in the heart, the novel treatments actually are not effective, and we need to use the Coumadin. So each patient may or may not have an indication for aspirin or for Coumadin or for another agent, and that has to be decided by the treating physician.
Okay.
Can I just interject a second? Because I think on this point, it's really important for the audience to know that one of the major severe stroke causes is what's called atrial fibrillation. And as was mentioned by Alberto, that's due to the fact that the heart is a problem. The atrium are not contracting, and clots form in the heart, and then they travel to the brain. And that has been shown by many NIH studies to be significantly preventable with anticoagulants like warfarin or the direct thrombin inhibitors. But again, the data out there is that people are being undertreated because of the complexities of using these medications. But there is nothing more complex to someone's life than suffering one of these strokes, because the atrial fibrillation strokes are usually the worst strokes of all.
Okay, one more question that's come in advance online. Can you talk about the link between chronic stress, mental health, and stroke risk? It seems that the risk factors for stroke can also be connected to mental health needs, but these links may not be considered in the doctor's office. Who wants to take that question? Umberto?
Yeah, Walter, go ahead.
Go ahead, Walter.
Right. So I think that this is understudied, that we know, for instance, that mortality rates are very high in people with autism and schizophrenia. Depression is not only a consequence of stroke, but it's a risk factor for stroke. And I don't think we understand exactly what the whole story here. Clearly, we know about the things we know, that they affect people's habits for eating, obesity, taking their medications, things like that. But I think a lot of people are worried that there's biology here we don't quite understand yet. But it's a very important question.
Okay. Maybe we take one from the audience. We have time for one in the audience. I think we have microphones around. Does anyone have any questions here?
Yes. Hi, I'm Dr. Enrique Caballero. I'm an endocrinologist. I work here at Harvard Medical School. I want to ask you about the prevention focus that you all actually talked about. That to me is crucial, because you all mentioned very rightfully so that most strokes can be prevented. I've been a co-investigator in the National Diabetes Prevention Program that Dr. Campia was referring to. And despite all the information out there about the fact that we can prevent diabetes, very few programs have been implemented throughout the country. And I think that our healthcare system focuses mostly on the treatment of the diseases and not on prevention programs and strategies. I'm talking more about community health level, primary care health level. And the same thing may apply to other factors like hypertension, obesity, etc. What do we need to do? What concrete steps do you think that we should follow in order to allow the healthcare system to better embrace prevention programs? I know reimbursement models are not working that well, et cetera. So in addition to improving treatments to people with strokes, how can we truly emphasize prevention programs?
Well, I will ring the bell for value-based payment. I don't know anyone who's serious about care delivery who doesn't believe that that would be a better model. The devil will be in the details. But it's not occurring fast enough. The transition is not occurring fast enough. And I know many clinicians feel like they have one leg in fee-for-service and one in value-based, and they're going to get split because it's just not working well enough. We do know that when you are rewarded for the outcomes you and your patients achieve, you're able to pay for the right team members. You might not be the best person to counsel your patient on physical activity or changing habits, but there are people out there that are really good at it. You need to be able to hire them. Likewise, you need the technology that helps you comb through your electronic health record and find out where the gaps are. Who's not getting a statin, who's a smoker and didn't get cessation treatment. Numerous examples of the way you would practice if you were really just rewarded for the outcome. So although it is happening too slowly and in too few places, I will keep advocating for that. And we're lucky in the Department of Health and Human Services because it is a priority there. And I think although the models we've had to date have not returned the value that we all sought, they are being scrutinized and revised, and I think more models will be coming.
Certainly, Janet, right, you're very humble because the Millions Heart program that you're running is targeting exactly this problem. So it's been a great program.
Thank you. So are there any more questions in the audience here? If not, we can go back to one more, I think another question or two that have come in online. And this is something I guess Gökhan alluded to. I don't know who the best person to take this is. What suggestions, medication, technologies, therapies, et cetera, do you have to regenerate brain cells years after a stroke for one with left side paralysis? So it's fairly specific, but maybe who's the person to take that one?
Yeah, I mean, I wish there was a single entity that I could say, okay, go buy this from the pharmacy. But although we're not there yet, I think we will be. So I'm extremely optimistic that there will be possibilities to replenish or repair the damaged neurons after stroke. But this is not something that is ready to be implemented at the moment.
What about another question here? It talks about in preventing disability. So for recovery, I wonder if someone can talk about what if someone who has just had a stroke, what are the things that they need to do to avoid having long-term permanent disability? Do you want to take that one? You're nodding, Janet? Or?
No, I was looking at Walter.
Okay,
I think
Walter,
that's
go.
right down his alley.
Yeah, so sorry. So the interesting thing about stroke is that if the patient survives, the patient always gets better. The nervous system is trying to get better. That's the general rule. Most people look at the evidence, and with some exceptions, people usually get about 70% better, but then it stalls. And what we don't understand is how the brain is rewiring, because unfortunately, you can grow new skin cells, but you can't grow brain cells pretty much. So what's happening is the brain is getting signals that there's a problem, and it's trying to rewire. And sometimes that works. It works better in younger people than it does in older people. So there's a big emphasis trying to understand what is actually happening. How do those circuits then improve or compensate? The Brain Initiative is a major program out of the NIH, which is trying to develop the tools to let us see circuit activity. And I think it'll be especially valuable in trying to understand this process. What we do know is that rehabilitation, intensive rehabilitation, seems to be the key to regaining function again. So we've done studies at NIH looking at one technology versus another. And what we find is that it's not the technology, but the intensity of the rehab. And sadly, in one of our studies, we compared what the standard rehab is to, and then brought in intensive rehab 6 months later and found that people improved. And this would not have happened in the regular rehab situation. So we also think that in the country, people who need rehab are not getting the level of intensity that will maximize their functional return. So another thing we need to work on.
Well, let me stick with you there, Walter, because I want to finish up here with ask each of the panelists to make a prediction about where we'll be in 10 years. It's a long time out for this kind of thing, but let's give it a shot. If you can't do 10, maybe 5. And think about, prevention, treatment, or recovery. And Walter, 10 years now, one of those fields, what do you think we're going to be looking at?
Well, so I'm an optimistic person. I'm going to say 10 years from now, 90% of people who have hypertension will have their hypertension controlled. And stroke, which was the third leading killer in the U.S., dropped to 5, will drop to below 10. So that's my prediction for prevention. I think in treatment, I think we're going to have drugs that we talked about, which can extend the time window so that more people can benefit from taking the clot out, and then we actually figure out how to improve people who have a hemorrhage into their brain, which is something that has eluded us so far. And in recovery, I think we'll understand some of the mysteries about how the brain tries to recover, and we'll be able to tweak those to enhance the recovery in people who have stroke.
Okay, well, you took all 3 of those fields, so let's go around this way. Gökhan, you've got a couple of minutes left.
I got to cover it all.
But if you want, you can do all 3 or pick one of those. Tell us what we're going to be looking at in 10 years.
Yeah, so I'm also an optimistic person. And so the things that I predict are, first, the stroke approach to stroke will be much highly individualized, that there will be better classification of stroke and then more informed decisions made both for prevention and treatment. The second is, I think, oftentimes we talk about treatment, we speak about mechanisms. We talk about prevention, we always talk about lifestyle. But there is a very important component to prevention, which is also mechanism-based. So without understanding the root causes of disease, it is not possible to implement the most effective preventive strategies. So my prediction is 10 years from now, the approach to prevention will be transformed to a mechanistic-based, well-informed interventions and cheap and broadly applicable interventions that can penetrate into population. And I think in terms of treatment, I mean, I see that in three areas. One is the repairing the brain. The other is, helping the body with the disability. So there's actually a tremendous amount of engineering innovation that will be extremely helpful to aid the body to deal with the sequel of stroke. And then the last is reversal. Really, I think that's the ultimate endpoint, is to develop the ways to reverse the damage, to reverse the sequel in the body or in the brain. So I don't know if it will happen in 10 years, but I'm very optimistic that it will happen in our lifetime, for sure.
Okay, thank you. Umberto?
So I am an optimistic too. I remember when I was in training in Italy in the 90s, and we just had heard about the approach with thrombolytics in stroke, and my professor was telling me, I hope that some days we will be able to do it for our patients. And now it's not only that, we have thrombectomy, we have these incredibly successful stories. And I hope that we continue with that trajectory, particularly with the new technologies. With regards to prevention, I hope that the disparities that we see now in 10 years will be sort of a history of the past, and we will look at us and think, well, what were we waiting for? The other optimistic aspect is that we have new drugs for prevention. We have the PCSK9 that are new drugs to lower cholesterol that can draw the LDL, the bad cholesterol, to levels that we had not ever thought possible. And now I treat my patients to targets that 10 years ago were considered science fiction. So in the last aspect, I think that we will have a better understanding of the prevention strategies at a population level that are going to be as successful as the overall smoking cessation with regards to the control of the obesity and diabetes epidemic.
Thank you. So you get the last word here.
I'd like to sign up for all of those things. And I'd also say that at home with the Million Hearts team, my nickname is Donna Quixote, so I am also somewhat of an optimist, or at least a windmill tilter. But the changes that I want to see in 10 years, is that when we talk about, we believe that heart disease and stroke can actually be prevented, but it's going to take public health and healthcare doing what they do best, not doing the same things, but doing what they do best and complementing each other. So I want in 2028 that the concept of public health and healthcare working together is not something that people go, oh yeah, that'd be cool, but that we're actually seeing that happen. I think the other thing I want to see is that individuals are empowered. They have what they need to be healthy. They are choosing those healthy things. We've cracked the code on behavior change in a way that helps move all of these trends in the other direction. We've tapped into the power of peers. The other thing I want to see is I want to see data that's available, that's trusted, that we get on a timely basis. We've seen some of that happen within healthcare systems. It's not happening between healthcare systems. An example is that Million Hearts ran for 5 years, and the first 5 years ended in 2016. I won't know until 2019 how many events were prevented. That is wrong. We have to have better access to more timely data. And then the last thing is about social norms, gets back to that peer power. Right, how do we get to a place where healthy is the thing everybody wants to be? and that we're willing to, and we can, invest in our own health and our family's health in a way that is reinforced. So that blood pressure control, we wouldn't let anyone go around without their blood pressure under control. We wouldn't let someone bounce around in a seat without a seat belt. We don't like it if somebody rides a bike without a helmet. And so how can we get to a place, hopefully before 2028, where we have that same sort of norm about blood pressure control?
Okay, thank you. That's the end of this. So thanks to the panelists, Janet, Umberto, Gokhan, Walter, thank you very much. And thanks to the audience here and online. And I just going to mention a shout out to the next forum, which will be on the 2018 midterm elections, key issues for healthcare. That'll be from noon to 1 on November 1st, 2018, here and at forum.hsph.org. Thank you very much. Thanks, all.